First of all, thank you for asking me to speak today. And it's a bit earlier than expected, but anyway, I was going to spoil your appetite because that's the nature of the topic. It was going to be either before or after lunch. And what I'll be speaking would be sort of more on a general terms with respect to this topic, because I wasn't sure about the range of the audience. But if there's anything specific that you'd like to discuss, I'm more than happy to just digress from my slides and talk about it. And no, it isn't. Sorry, I'll use it here. So this posterior pelvic floor dysfunction is not a topic that either the patients or doctors talk about very freely for more than one reason. First of all, it's not something that's a social conversation. And secondly, it's always been neglected because it's not very obvious. It's something that patient suffers but doesn't talk about it. So it's also called as a silent sufferer. And so with that sort of brief introduction to this topic, we'll go off to the main topic itself. And this problem actually deals with a variety of different conditions. In fact, there are so many conditions attributable to pelvic floor dysfunction. It's impossible to speak about all of them. So I'll be concentrating on the posterior pelvic floor, which is more to do with the anorectal area. And the two most common and disabling symptoms that it can cause would be fecal incontinence and evacuatory dysfunction, which would be what we would see more often in the clinic. And because this can actually cause problems in more than one area, the patients can be referred to different specialists, and that is where part of the confusion might lie. So there's increasing sort of awareness that all these will need to be managed under one umbrella in a multidisciplinary setting. So the first thing is, why are we talking about it today? Because there are so many more interesting topics, as you can see from the program. The reason is that this is a problem which is not rare, which is not something that doesn't exist. Because there have been so many surveys done, and it's been shown that it's larger, the incidence is larger than what one would think. And the second thing is, even though it may not kill the patient, it can actually lead to a very poor quality of life. And if you're talking about adding life to the years rather than just years to the life, this is one condition where we need to be, I think, concentrating. And over the last couple of decades especially, the pathogenesis of this problem is much better understood, and there are investigations available to confirm the diagnosis as well as various treatments to address it. So for all these reasons, I feel we need to give more publicity as well as a higher profile to this problem. Before we go into the problem itself, we need to know a little bit about what actually the pelvic floor is. And it's quite a complex structure. And because it's sort of neither here nor there, it's just below the abdomen but above what we would think of the pelvis, people haven't really even considered this very much. Even during our medical school days, probably when we were dissecting, pelvic floor wasn't really considered as a very important part of our dissection. It has multiple layers. It's not just one single layer. There's the levator ana in the upper part and the urogenital diaphragm lower down. And it's also an integrated structure. It's not just one single structure. There are muscles, there are fascia, there are ligaments, and there's a bony rim. So it is actually quite complex from that point of view. And just to jog our memory, looking at it either from the top or from the bottom, once we remove the surface coverings, these are the different types of muscles that we'll encounter. Each bit of muscle has its own role, and it's only when it doesn't work do we actually become aware about what it does. And especially if you look at the diagram here, we can see the pelvic floor, the levator ani, is actually colored in different ways, only to show that each one has a different role. The one that's very close to the viscera, in the middle you can see there is what we call hiatus, 3 hiatus or openings in the pelvic floor for the anorectum, vagina, and the urethra. And the one that's closest to it is called the visceral part of the levator ani, which actually is most involved with continence, whereas the ones which actually form the supports are more likely to be important when it comes to prolapse. So with that brief introduction about the structure, the main functions would be giving passive and active support. So it's not just giving support, it's actually different types of support. The passive support is due to the ligaments and the fascia, and the active support is due to the muscles, which can contract and relax accordingly. By doing this, they also help with the continence, because we need to have some spasm, some amount of contraction when we need to have continence, and when we need to, the muscles need to relax when there's defecation or micturition. So it is actually a very dynamic area. So the next issue is what causes this not to work in the way it should. There are lots of causes, and this is not by any means the complete list, but at least it involves all the important ones. And I think if you look at the profile of the patients, 9 times out of 10 it's going to be a female. And for these reasons, I think the 2 factors which I feel contributes maximum would be the obstetric factors, pregnancy and delivery related, as well as the anatomy of the pelvis itself with a larger hiatus and a larger pelvic outlet. But all the others do contribute as well. So when we are looking at the patient, I think we need to make sure that we consider all these things. So when it doesn't work, when they fail to do what they have to do, what consequences can it lead to? Broadly speaking, these are the symptoms that the patient may present to us with. Pain is a very vague and difficult symptom, and that could be again due to lots of things, and pain itself can be in various ways. Prolapse is much more straightforward, much more obvious when things are not in the right place. They just slip out of place. Prolapse means to slip, and that's what happens here. And of course, in posterior pelvic compartment, it's a rectal prolapse that we'll be thinking about. And when we talk about urogenital dysfunction, again, that's something in the anterior compartment, sexual dysfunction in the middle compartment, and anorectal dysfunction predominantly presenting as either fecal incontinence or difficulty in evacuation, which is what is known as obstructed defecation syndrome. And some of these terms can be confusing, but they all refer to the same thing, that the act of defecation is not going on as it should. So I'll now sort of talk a few points about each of these consequences, and along with that we'll also see what might be the cures or the treatments for this. Fecal incontinence is something that everyone dreads, and unfortunately that's one of the benign conditions that can affect the quality of life to the maximum. I'm not going to speak in detail about fecal incontinence, but only as it refers or as it is related to the pelvic floor dysfunction, because a large number of patients with fecal incontinence might have problems with the anal sphincter. So that's not, strictly speaking, pelvic floor dysfunction. But when we talk about pelvic floor dysfunction, either they have evacuatory dysfunction or something to do with the nerves and muscles that's affecting the process, and consequently some leakage. So it's a bit more difficult to treat the incontinence, because it's not just the incontinence you're thinking of. The cause of the incontinence is equally important. Depending on what their underlying pelvic floor dysfunction is, if there's any problem with their rectal sensation, either increased sensation, rectal hypersensitivity, or decreased sensation called rectal hyposensitivity, then accordingly, either to the same amounts of stools, the stimulation is increased, and then they have problems with urgency and urge incontinence. Or in rectal hyposensitivity, there's reduced sensation, though there's impaction, and post-defecation leakage. So sensation can affect it. And of course, decreased compliance. Whenever there's rectal hyposensitivity, it leads to megarectum. Whenever they've had any operation, and that can lead to what we call anterior section syndrome, where the compliance is affected again. Prolapse, by definition, anyone with prolapse will always have a bit of leakage or variable degrees of leakage, because it stretches the anorectal ring as it comes out. Stretched neuropathy is something that wasn't understood initially, because if someone has evacuatory dysfunction, because of the straining itself, they keep stretching their nerves. And nerves are like rubber bands, elastic. So they lose elasticity, and that leads to this condition. And of course, they can also have occult sphincter trauma to add to all these problems. So there are so many reasons why they can have fecal incontinence when they have pelvic floor dysfunction. And accordingly, we'll need to see what we can do. If it was just a simple case of the sphincters not being intact, Then, of course, the direct repair has been followed for a long time, and none more so when they have this injury during childbirth. It's a primary repair, and the results are excellent. But when they have more associated complicated problems, that needs a different approach. And so surgery is by and large not rushed into. In fact, by and large we avoid it. Biofeedback is something that has become increasingly important, and basically what it does is it teaches the person more about their evacuatory function, and it's an audio-visual feedback, and they use either what we call EMG or the anal manometry, and on the screen, actually it's very good, either they get a visual feedback where they'll see how the curves are going up and down, or they can make the seahorse go up and down in the water. I mean, there are different sort of screensavers that they can use to make their understanding maximum. Or it's just a visual, this one auditory or a bleep when they're relaxing and squeezing. Neuromodulation is again something that's been extremely helpful. SNS just means sacral nerve stimulation, and PTNS is a peripheral type of stimulation, pretibial nerve stimulation, which is what is becoming increasingly popular because it's non-invasive, and the results are actually not bad and sort of comparable to the sacral nerve stimulation. So this is something that actually has become quite a mainstay of treatment. Along with this, they'll always have a course of physiotherapy, because as with everything, if you strengthen the muscle, there's always a bit of improvement with bowel retraining. Anal bulking agents, you are just trying to increase the bulk in the anal sphincter muscle, because when there's a nerve injury, there's always some degeneration. When there's degeneration, the sphincter complex narrows or thins out. So this just adds to the bulk of the anal sphincters, which again can be helpful. They all have a success rate of about 60 to 70%. And unfortunately, they're not always permanent. In fact, most of them are not, because the process is continuing and ongoing. So sometimes you have to repeat either the injections or the neuromodulation. SECA therapy is not as popular as they thought it would be. They use radiofrequency stimulation, and again, that's helpful when there's degeneration. Transanal irrigation doesn't do anything to the sphincter muscles itself. It just sort of takes away whatever stools are not being emptied, and that again is quite helpful. And what we need to remember is, it's not that we have to use only one of this. It's usually a combination, and usually it's a three-pronged approach. We may use some physiotherapy and bowel retraining to help improve the defecation dynamics, somewhat of neuromodulation to help improve the anal sphincter squeeze, and then transanal irrigation to help keep the rectum empty. So in fact, it is a multi-pronged regimen. So that's about fecal incontinence. I don't want to go on about it. And of course, I'm prepared to answer any questions if you have any specific ones. Obstructive defecation syndrome, as I said, is more of an umbrella term, and people have called it various terms, but what it means is they have a desire to evacuate, but they are unable to satisfactorily empty the rectum. So if they don't even have a desire to evacuate, then that tells us something about the nerves, which we'll come to in a minute. So the way they'll present to you would be with any of these symptoms, probably a lot of them. And whenever they come with these symptoms, the physician will need to think about an underlying ODS, because that is where sometimes the delay can be, because we don't normally think about the functional bowel disorders. We start thinking of any organic pathology or something else that the patient can do without understanding that there could be an underlying pelvic floor function. And if you look at the X-ray on the right side, you can see all the transit markers. This is a colon transit study, which means they get 3 capsules. There are different protocols, but they get some capsules to take, and after 5 days they have an X-ray. And depending on how many of them are still there and where they are, we know how slow the traffic is and where the traffic holdup is. So in pelvic outlet problems, typically they'll all be sitting in the pelvis because they don't move out. So that would be the typical picture there. And there are different causes of ODS. As I said, it could be due to altered rectal sensation. And that's where they get some sort of a strange sensation to open their bowels. It's not the normal sensation, and they never know when they've emptied. Or it could be due to failure to relax, because not many people realize when we open our bowels, the evacuation is similar to the process of getting toothpaste out of a toothpaste tube. There are 2 steps. The first is to open the cap of the toothpaste tube. The second is to squeeze the tube from the bottom. And here opening the cap is relaxing the anal sphincter muscles, and squeezing the tube is the top of the rectum squeezing it out. If the coordination is not there, then it's called as dyssynergia. There are different types of dyssynergia, and it's also called as anismus when there's failure to relax. And in Hirschsprung's, of course, that's the more popular condition where this happens. Mechanical obstruction can also affect the emptying of the back passage. Interoception is just internal prolapse. It's just like telescoping. The upper part of rectum just telescopes into the lower part, and in the process, it actually narrows the lumen because it causes a funnel effect, and that causes occlusion. And sometimes they push. The more they push, the more ineffectual it is because they'll be pushing in the wrong direction. If they have a rectocele, it will just be going off towards the front, or the perineum will be pushing. It's just like when you're tightening a screw, as long as you make sure that it's actually held proper, otherwise you'll just be tightening and it'll just be going on. Similarly, if the perineum is also descending, then the more they push, the perineum descends and nothing happens. So there are various reasons why the evacuation may be affected. But as a result of that, apart from the symptoms that we were talking about, they can actually also have several different conditions, and these are sometimes more common and more popular with the physicians. Hemorrhoids and anal fissure, I'm sure a lot of surgeons and non-surgeons will see. Rectocele, rectal prolapse, and fecal incontinence and pain we already talked about. So it can lead to a lot of sequelae. And of course, each of these may have its own way of this one. When you say interoception, it is internal rectal prolapse, the telescoping, and this one illustrates how it actually progresses. You can see this is the upper part of the rectum which is coming down into the lower part, and as it does, it actually narrows this area and it develops wings, and depending on how much it comes down, it's called grade 1 to grade 4, and then it becomes overt rectal prolapse. So when we do this evacuative proctogram, we also see whether it's occluding, and if so, if that is the cause of obstruction. And when it comes down, the apex of the prolapsing tube actually rubs against the lower part of the rectum, and that gets eroded, and that is what is typically called the rectal ulcer syndrome or solitary rectal ulcer syndrome. And for a long time, people didn't know what or how it was caused, and various theories were put forward, but this is the reason for it. It's as a result of chronic erosion of the area because of straining and internal prolapse. And when that happens, and if it's occluding, this is one of the operations that can be done. But before we go into any operation, we need to remember we always try the non-surgical methods, and these patients will be discussed in the pelvic floor MDT, and only then will the operation be done. And this is logically a very good technique, because what it does is a mesh is put in between the vagina and the rectum, the uterus and the rectum, and that is hitched here lower down, as well as the sacral promontory. By doing that, it straightens what would otherwise be a very floppy rectum, and that improves the evacuation. As with everything, nothing is perfect, because having a mesh so close to all these organs, you need to be careful about infection and erosion, and there's always a certain degree of patients who will get these problems. And secondly, you need to understand this prolapse is just a consequence of an underlying problem. So it doesn't mean that we are correcting the root cause, we are only correcting the consequence. So they can still continue to have some amount of bowel symptoms despite this. There's one more alternative procedure which actually is associated with lower morbidity because it's done from below. And this is also a very nice operation where it's like stapled anopexy, which is one of the operations we do for the piles, but we remove full thickness of the rectal wall to straighten what is otherwise coming down. So again, this has its advantages and disadvantages. Whenever you do this from below, if they already have some sphincter problems, that can increase the urgency and urge leakage, so you need to be very careful. And secondly, when you're doing it from below, it's essentially a blind procedure. So you either combine this with a laparoscopy or be very careful when they have an enterocele or sigmoidocele, because we can have injuries to the vagina and the small bowel. Anal fissure and hemorrhoids, we don't need to go on about them because they're very well known. And they're sort of partners in crime because they occur under similar conditions. So sometimes, we never know which one is the predominant problem, because both cause anal pain and bleeding. But if pain is the predominant symptom, it's more likely to be fissure. But what is important is, whenever they have a failure of standard treatments for these problems, or they have recurrent episodes, you need to suspect that there could be an underlying rectal evacuatory problem, and these are just the consequence of that. So you need to look for these signs, look for this one, and do the physiology test to further sort of investigate that. That would be the take-home message. And when we do the anal fissure operation, the gold standard or traditional technique is to cut the internal sphincter, what is known as the lateral internal sphincterotomy. But by and large, I haven't actually been doing it for almost 10 years now, because if you cut a sphincter, cut something to make something else normal, it's never good. So I do these anal flaps. You can see the two sphincters, the internal and external. So we take a flap of skin from the surrounding area. And apart from this, we also inject Botox into the sphincters at that time. And then this goes and covers it to provide a patch over the flap, over the fissure. So that's one thing that I would strongly sort of recommend should be done more often than lateral internal sphincterotomy, especially in these patients. And for piles, the traditional method has been Milligan-Morgan, which is excision of the piles, but that itself, again, has its own problems with increased pain. So for quite some time now, almost 20 years, stapled anopexy has been used, and now I think it's probably the most popular way. There are newer techniques which are a little less invasive, like the halo procedure, but by and large, I think you need to make sure we tailor the procedure to suit whatever is most appropriate for that patient. Rectocele, this can mean different things to different people. To the gynecologist, usually it means some amount of vaginal prolapse or dyspareunia or vaginal lump, and the patient may present with any of these symptoms. But it becomes more relevant to the colorectal surgeons when they have associated evacuatory function. And the diagnosis is a clinical diagnosis, but we always evaluate this by investigations to know how significant it is. Is it incidental or the cause of the symptoms? And when we are talking of treatment, we always make sure we tailor it. We don't rush into operation, but we need to do it when it's causing significant symptoms, not responding to other treatments. So when we do an evacuatory proctogram, this pocket that develops towards the vagina is what is called a rectocele. And as you can see, a lot of contrast is going there. The same thing happens to stools. And so sometimes they have to digitate to empty it, or despite that, they may not empty and are left with symptoms of incomplete emptying. And this is something which, again, was not very well understood. You remember about the toothpaste and the designification examples that I gave. This is what will happen in these patients. Because normally there is an angle, and anorectal angle. When during defecation, this angle becomes more obtuse. That means it facilitates the emptying, and that is because of relaxation of pubo rectalis. But in some people, that actually has paradoxical contraction. It increases. So the more they strain, the more it obstructs. So this is just to describe the dyssynergia and the underlying pathogenesis. How many more minutes do I have? Can I ask?
No problem.
Is it? Okay, that's fine. Please stop me whenever you think I'm just running away. So this again is just sort of, explaining the same process and the role of pubo rectalis, because people didn't realize that pubo rectalis is in a way a distinct entity from the rest of the levator ani. In fact, it's closer to the external sphincter than the rest of the levator ani. So that's something I think one should remember when treating these patients. Rectal prolapse is something very obvious, something that's been known because it's seen on the outside, unlike many of the other things that are not seen on the outside. But what we need to remember about this is it's a progressive condition, like any hernia or any mechanical problems. With time, it can only get worse. And it will lead to poor quality of life because apart from the prolapse, it's always associated with incontinence. And so for these reasons, by and large, surgery is required in most cases. It's very rare that we would say we won't operate because the patient is old or frail. And there are different options of treatment which can be done even in quite elderly patients. But we need to make sure that we select the right procedure for that patient, and we explain to them that there's a very high chance of recurrence because, again, we are treating the consequence, not the root cause. All of them usually have very poor pelvic floor, as well as some amount of incontinence. Usually, if you look at the scores for incontinence reduced by about 50%, but we don't assure or we don't actually guarantee that the incontinence will go away because the underlying muscle weakness will still be there. So these are some of the things that we need to remember while treating any patients with prolapse. If you remember this figure, it tells us why the prolapse happens. And there are three important things here. You can see there's a hammock, and there's a couple actually enjoying some rest there. And then the two poles which actually suspends the hammock. And this actually compares well with what happens in the pelvis. The two poles, supporting poles, would be the pelvic side walls, the bony side walls. And the pelvic floor is the hammock. And the rectum and all the other pelvic viscera would be the ones which are actually being suspended. So if there's a problem in any of these, you know what happens, they'll fall to the ground. So similarly, when the pelvic floor, the hammock actually stretches so much or can't support the viscera, that's what happens. And it doesn't happen overnight, it's a progressive process. It usually starts off as an internal prolapse or intersusception, as we saw. And then it's usually the anterior wall that starts coming out. So we call this anterior mucosal prolapse. Then it becomes sort of full thickness or mucosal prolapse with somewhat of full thickness prolapse, which increases in size. Once it stays out for any length of time, it becomes edematous, ulcerated, infected, and even gangrenous. So these are the consequences of irreducible hernia as such. So that's something we need to be aware of. So various ways of treating it from above and from below. And by and large, nowadays, it's what we call a sutured rectopexy. That's the most popular, because previously they used a lot of these meshes in different ways. Then they realized when you use a mesh, it may cure the prolapse, but it can cause a different problem, constipation, because the rectum has to be free to be able to empty without any problems. And the mesh is a constricting area, and that causes a lot of dense fibrosis. So the function is gone, even though it may not fall out of place. So suturing it is good, but when you suture it again, you may have to dissect the nerves. That can cause constipation. That's the reason why it's now ventral rectopexy, where they don't go into the nerve area at the back. And from below, there are lots of different things described. Altmeier's procedure and Delorme's, these are the ones which have low morbidity. You can do it even in elderly patients with a spinal, under a spinal or even caudal block, so you don't require GA. For small prolapse, mucosal prolapse, Delorme's is a very good operation, but if you try to do it for full thickness prolapse, it has an unacceptable recurrence rate. That's why Altmeier's is better, where we resect the bowel from below. And you can resect quite a lot of bowel, about 2 feet or more than that from below, which is actually incredible. It's only something that you need to see to be amazed. I've left it to the last because this is something where we really can struggle in many patients. Many of them present mainly with pain. That is when you need to be careful. That's when the warning bells should ring, because pain is not a very good thing that we can actually treat as surgeons especially. And there are different causes of this pain in pelvic floor dysfunction, but the two main conditions would be levator syndrome, which is spasm of the pelvic floor, or just pressure on the pelvic floor itself, or proctalgia physiax. And this is more due to sudden spasms of puborectalis or the external anal sphincter. And typically this pain is very transient but can be quite severe and sharp. And it's more often in the males because they have higher pressures in the sphincters and puborectalis. And again, this is self-limiting but can be quite difficult. And physical examination, everything will be completely normal. In levator syndrome, this is more of pelvic congestion and heaviness, as well as spasm of the pelvic floor, more common in females, and it's more of a chronic discomfort. They don't get any sort of relief in any position, and it's always like sitting on a fence or sitting on a ball. So it is again a very difficult condition. And when we talk about management, and if there are a lot of things under that, it shows that none of them are actually effective in all cases, and that is exactly what it is here. So we tried various things, and by and large, either the problem goes away or the patient goes away, or somehow we crack it. But it is a very difficult area. People have tried various things. Some of them can also be disastrous because if it's not done in the right patient. So that is more of an overview of pelvic floor disorders. Just to summarize, we need to be aware about all the different symptoms that a pelvic floor dysfunction can cause. And these are common symptoms, which is why we don't think or associate them with pelvic floor dysfunction all the time. But we'll need to always make sure that when the symptoms are not going away or they come back despite the first line of treatment, you have to think of underlying pelvic floor problems. It's a teamwork. Because it involves so many organs, because it can cause so many symptoms, it's impossible for one person in one specialty to be able to deal with this. So there is an MDT, there is a team, so we need to make sure that these are actually managed properly in a pelvic unit rather than by individual clinicians. And there are various objective investigations which are now the mainstay and routinely done for these patients. And these are objective investigations, they are not just subjective, they actually give us in so many values, we know what is normal, what is abnormal, what the response to treatment is. So it is actually a lot more controlled. And it's done in various departments, so it's again something where you'll require the cooperation of different members in the hospital. And there are various non-surgical treatments, and I have to say that these have really changed the lives of many a patient. So our approach has changed, and we no longer ask them to just go home and suffer or just give them laxatives or some sort of very broad based and non-specific medications and treatments. So these are actually a lot more targeted, focused, and they're all, whenever we treat these patients, we have the condition-specific questionnaires, we'll have quality of life questionnaires and symptom scoring questionnaires, which are repeated after treatment, so we'll know exactly what the response has been. So it is actually quite a well-planned treatment. There are lots of surgical procedures which are done because by and large most of them don't require operations. It's only about 20 to 25% of these patients who require operation, but nevertheless some of them do. And as I said, there is a wide array, but you don't rush into this. And I think, just the take-home message is if you need to know the real nature of the beast, you need to make sure that you examine it comprehensively. You take the collective message from all the examinations rather than jumping to conclusion, because it can present in different ways and it can be associated with different symptoms as well as underlying problems. So that is what I think would be the best take-home message I can give. Thank you very much.